I think we can start.
I think we can start.
Are we rolling?
Lights, camera,
Action.
action.
Welcome to our podcast, Making Clerkship Click, with your hosts, Tanmay, William, and Nick. If you're a medical student, this is a podcast just for you to get quick and easy primers on high-yield medicine topics that you're likely to come across when you go through your clerkship blocks. So let's dive right in.
All right, welcome to the inaugural episode of Making Clerkship Click.
Let's go.
Wow.
My name is William, and I'm joined by my two co-hosts, Nick and Tanmay. Together, we are three third-year medical students currently completing clerkship at a Canadian medical school. So, just to begin, the concept of this podcast is simple. We're trying to give you guys quick episodes on major topics you'll encounter during clerkship on all your different various rotations. It's meant to provide some baseline knowledge to build upon as you gain experience and read more in depth.
Absolutely. We are super excited to bring this podcast to you. Through our episodes, we're hoping to share some helpful tidbits, to talk about some high-yield topics, and hopefully this can help you become a superstar clerk on the wards.
I like the sounds of that.
So an important disclaimer for this episode and all future episodes. We are medical students, not yet medical doctors, and this podcast is not meant to be medical advice. The information we're presenting to you is based on our previous lectures, research we've done, national guidelines, as well as our own clinical experience, and it's not meant to guide clinical practice or decision making.
So guys, what's on the menu today? What are we talking about?
Tanmay, can you tell me actually? I was hoping you could tell me.
All right, so we are talking about acute gastrointestinal bleeding.
That sounds pretty scary.
GI bleeding. Very scary.
Oh, goodness.
Hopefully by the end of the podcast, this would be a topic that is a lot more approachable for you, something that you can kind of, just feel very comfortable with. So this is a common problem you'll encounter in various rotations: internal medicine, surgery, emergency medicine, pediatrics, possibly even family medicine. So super high yield and super important to have an approach to. So Nick, we're thinking of GI bleed. What's our approach?
So a really useful approach for when you're approaching a patient with a possible GI bleed is you want to think of the upper gastrointestinal system and the lower gastrointestinal system. And you can divide these with a landmark suspensory ligament, and this is the ligament of Treitz. So this attaches to the duodenojejunal junction, and it separates the upper gastrointestinal tract from the lower gastrointestinal tract. And if you have bleeding in either of these sites, you'll have different symptoms in that specific patient. So William, what do you commonly see in a patient with upper or lower GI bleeding?
All right, so for GI bleeds in general, we're looking at the big three symptoms. So the first is hematemesis, which is bloody vomitus. So it's either bright red blood or it kind of looks like coffee grounds, actually. And the reason why blood can look like coffee grounds when you vomit it up is that this blood can be digested by stomach acid. Kind of gives it that unique color. Second thing you can see is melena, which is dark, sticky, tarry stool. Again, indicative of digested blood. The third thing you can see is hematochezia, which is blood passing per rectum, right? If you see hematemesis or melena, it's more likely to be an upper GI bleed. If you see hematochezia, it could either be a lower GI bleed or just a really fast, really brisk upper GI bleed. So now that we've kind of gone through this, we're going to get to the fun bit, the meat and potatoes. Tanmay, can you bring us through a differential?
So let's start with upper GI bleeds first, right? If that's what you're suspecting based on the signs and symptoms that we've talked about, the causes can really be divided into two categories: variceal and non-variceal causes. And that becomes important from a management standpoint, right? Which we'll talk about later on. So variceal bleeds are seen in patients with cirrhosis or chronic advanced liver disease. And you might ask, what are varices? So what happens in cirrhotic patients is you get increased portal pressures or portal hypertension. And because of fibrosis of the liver, what's basically happening is you're getting this increased intrahepatic vascular resistance. So because the blood is having a hard time getting through the liver, it starts going through collateral vessels that are connecting the portal and systemic circulations. And these collateral vessels dilate as a result of that. And that's varices. So you can get these enlarged veins around the esophagus or the gastric area in patients with advanced liver disease or cirrhosis. And these vessels aren't actually designed to carry large volumes of blood, right? They're just collateral vessels. So when that does happen as a result of cirrhosis, they actually become quite friable. They can leak, and they're also at increased risk of bursting. So in patients with history of cirrhosis, if they're presenting with upper GI bleed signs, you really want to consider a variceal upper GI bleed on your differential. Doesn't mean it couldn't be something else, but you suspect a variceal cause and manage accordingly till proven otherwise. Now, in those with no such history, you can start thinking about the other category, which would be your non-variceal causes of upper GI bleed. And with this one, there are multiple possibilities. There's multiple non-variceal causes, so the differential is wide, and the history can again be quite useful in pointing one way or the other.
Something that's very common is peptic ulcer disease, or just inflammation of your gastric mucosa, or like esophagus or duodenum. So you can get like a gastritis, esophagitis, or duodenitis. And common causes for this are NSAIDs, Advil, for example, alcohol, steroids, other NSAIDs like aspirin or naproxen. Or you could have infectious causes like H. pylori, which is a common cause of upper GI inflammation. Another common cause would be a Mallory-Weiss tear. This is caused by prolonged or severe retching, which results in a partial mucosal tear at the GE junction, or the gastroesophageal junction. And again, commonly seen in sort of the alcoholic population, because you see a lot of retching in those patients. So something, if you see a patient like that, something that should sort of be on your differential for sure.
So you're vomiting so hard you bleed?
You're vomiting so hard that the physical stress of like that, just vomiting and retching, is just causing that sort of tear in your GE junction. So yeah, it's kind of like physical trauma at that point.
Okay.
Other causes, stress ulcers, could be secondary to episodes of just general shock, sepsis, surgery, trauma, burn. So like your vascular blood supply to your stomach or to your upper GI system is just compromised. You're developing stress ulcers. Or something more common, or something that you'd think would be more intuitive, would be like something like a malignancy. Obviously, if you have like a tumor in there, some sort of like gastric cancer, esophageal cancer, could be another source of an upper GI bleed. So just divide it into variceal versus non-variceal. Variceals in your sort of liver disease patients, your cirrhotic patients. Non-variceal, you're thinking of some of those other causes.
I'm just going to jump in here and talk about that. One of the causes we discussed during my vascular surgery rotation a couple months ago, which is rare but one to think about, is an aortoenteric fistula. And what this is we actually have a connection that forms between the aorta, that very large blood vessel carrying arterial blood in the thorax and in the abdomen, and that can connect actually to some part of your bowel. And so that sounds really scary, because it is, and you can have massive amounts of blood loss extremely quickly. And so in these patients to consider for this rare cause of gastrointestinal bleeding are largely those who've had a previous AAA or abdominal aortic aneurysm repair, be that a open repair or endovascular repair. You want to think about the possibility of this rare cause of their bleeding. So now moving on to the lower gastrointestinal bleeding. So patients with this type of bleeding are more likely to present with that hematochezia, so that red blood per the rectum, less likely to see that hematemesis, where they're vomiting up blood or coffee ground looking substance, or that melena stool. Here, there's a number of different things we want to consider. One of the really common ones is diverticular disease. So these are the patients who have diverticuli, and that they bleed because the blood vessels that perforate into the colon are very close to the surface, and basically they can get worn into and you can get bleeding. For this, you want to think about patients who have a history of pretty bad constipation. Also, if the patient has known diverticuli, so if they were seen on a previous colonoscopy or a previous CT, you want to think about this cause. Next up, you want to think about different malignancies. So this is largely in the colorectal area. You can also think of polyps, because they can also cause bleeding. Here you want to ask patients about constitutional symptoms. So have they had the unexplained fevers? Have they had unintentional weight loss? Have they had night sweats? Then you might be starting to think, maybe this is more of a malignancy. Now moving to the end of the gastrointestinal system, we have the anorectal causes. So things like hemorrhoids or fissures. These can also cause lower GI bleeding. Here you want to ask patients, have you had more blood-streaked stools, or have they just really seen blood with wiping after they go to the bathroom? Then you're starting to think of these causes. Also, we have different types of colitis. So you can have ischemic colitis, you can have infectious colitis, you can have inflammatory colitis. And some of the key causes of that inflammatory colitis being Crohn's disease or ulcerative colitis. You can also have an patient with angiodysplasia, and this is where you have this abnormal blood vessels that develop, and they can actually bleed just because they're formed improperly.
Nick, can I ask a question here, actually?
For sure.
Like I'm thinking peds to be honest right
Oh
now.
yeah,
Like is my differential the same?
that's a good point. You're probably not thinking diverticular disease in a child, though you could try saying that to your preceptor, that they might give you a funny look. A couple of things, yeah,
I'm not gonna match. I'm not gonna ask that question. Yeah.
yeah. But a couple of things you do want to think about in peds would be intussusception. So that's a really interesting cause where basically you have one part of the bowel actually prolapses into the next segment, and it causes something called this telescoping effect. And these patients can have this on and off bleeding that commonly presents like these, they're called jelly stools, very specific sort of presentation. They're not always seen, but you'll get that really interesting telescoping effect in patients with intussusception. Another cause to think about is malrotation with volvulus. This you'll commonly see much earlier in life. And this one is actually quite devastating because basically you have this improper rotation of the intestines and it can cause really significant bleeding. So there you go. There's a couple peds ones.
Nick, you've just saved my carm cycle. I appreciate it.
You're welcome. You're welcome.
All right. So, guys, let's set the stage with a case here.
Yes, sir.
William, you are a resident on call.
Oh boy. Okay.
I am an emerge doc, and I give you a call and I say, hey, I have a patient here, a 35-year-old male with signs of a GI bleed, some sort of low hemoglobin. Could you come see this patient? So now walk me through what's your thought process. You go to the emerge, you go down, you see this patient. What are you thinking? How do you want to approach this patient in terms of investigations and so on and so forth?
So first, I'd need 30 seconds to get over the imminent panic of being called. But after I recover my sense of composure, the thing is actually quite simple. Okay, so I'm gonna break this down nice and easily for you guys. Before any investigations, you're gonna want to ask one question to yourself. Okay, is the patient stable or unstable? If the patient's unstable, call for help immediately. That's it. Okay. What you're going to do is you're going to get vitals here. You're going to check their ABCs, airway, breathing, and circulation. So make sure the airway is patent. You're going to give them supplemental oxygen, and you're going to get 2 large bore IVs placed.
So the fundamentals, just see if they're stable or not.
The basics.
Okay.
The basics are basic. We're going to try and keep the patient alive first and foremost, right?
Right.
We're going to give fluids to maintain perfusion. If they're unstable and actively losing blood, though, you'll probably want to call the blood bank ASAP and just get red blood cell transfusions going. Because the best management for hemorrhagic shock is giving blood. You should also get like a type in cross match so you can switch from O negative to more targeted blood products later on. In terms of testing, you're gonna want to get a CBC, so a complete blood count. You're gonna want to get electrolytes, liver function test, so an INR, APTT, looking for any kind of clotting dysfunction. You're gonna get a VBG and lactate. A VBG, for those who don't know, is a venous blood gas. I just say VBG to sound fancy, but this is an easy way to check for any potential acidosis secondary to like a loss of perfusion. Also, another thing I'd like to mention here is a cardiac workup in selected patients. So you're going to want to order an EKG and cardiac enzymes to rule out an MI in people at risk. So like older people, those with a history of coronary artery disease, or patients with chest pain or shortness of breath. With blood loss, the heart has to work harder to make sure oxygen delivery is the same, and that can kind of push some people into a myocardial infarction. Finally, you're going to want to call GI or general surgery and get an upper endoscopy or colonoscopy, depending on where the bleed is coming from, where you think it's coming from. So now, tell me, we've gotten the investigations. Bring us through how to manage this.
Yeah. So, I mean, before I go to that, I guess the key takeaway there was that the VBG is venous blood gas, but if you want to sound cool, you can just say VBG.
Of course.
Oh, yeah.
Always go with acronyms.
Perfect.
Always go with acronyms.
CBC sounded pretty cool too. Like when we're getting a CBC, are we getting the Canadian Broadcasting Corporation or who are we getting?
Listen, in first year, that sounded so impressive to me too.
Yeah.
You know? So in case you guys want to flex, keep that. That might be the real take-home point of this episode.
It's a complete blood count. It's not the Canadian
Complete.
Broadcasting. Okay, gotcha. All right, cool. So now that we're all cool here.
The Cool Kids Club is established. Yeah.
Amazing.
Bring us through the management here.
All right, so from a management perspective, once you have them stabilized, the next step is to localize the bleed. You make them NPO, and then you consult GI or general surgery to do an endoscopy. But there are a couple things you can do on the wards or on the floor before your patient goes for an endoscopy. The one thing in upper GI bleeds that you can do is start them on a proton pump inhibitor. You can start them, for example, on IV Pantalog drip if you're suspecting an upper GI bleed, because what acids do is they interfere with clotting. So your stomach acid can interfere with clotting, and that can precipitate further bleeding. So when you give them Pantelok, that would sort of mitigate some of those negative effects of the acid. A special mention for variceal bleeding, which is sort of the upper GI bleeding with your liver disease patients, is you want to start them on a cocktail of 3 separate drugs. One of them would be the PPI, which you're starting with every upper GI bleed. But the other 2 would be ceftriaxone, the antibiotic, and octreotide. Now, ceftriaxone actually has a mortality benefit. It's the only drug that has a mortality benefit out of the 3 with upper GI bleed. And octreotide, what it does is it decreases the inflow of blood to the portal system by constricting the splanchnic arterioles and significantly reducing the intravaricial pressure. So it takes some of the load off those varices.
Tammy, I'm a curious clerk. Do you mind if I just jump in here and ask a question?
Yes, sir.
So, like, why would we give an antibiotic for a GI bleed? It doesn't really make sense to me.
Yeah, so I mean, we're talking about variceal bleeding here, right? So patients with chronic liver disease, cirrhosis, these patients are immunocompromised. That's where ceftriaxone as an antibiotic can offer a mortality benefit.
Okay, makes sense. That makes sense.
Does that make sense?
Always wondered.
Yeah. Okay. So following that, again, like I said before, you kind of ship them off for endoscopy, and that can have both diagnostic and sort of therapeutic utility. So in some cases, a scope might not be able to find or localize the bleed. In those particular cases, there are other tests that can be conducted. One of them would be a CT angiography. It can help localize a GI bleed through extravasation of contrast. Other possible options could be a tagged red blood cell scan. But these are sort of tests that are done down the line. Usually a scope, whether it's an upper scope like or a lower sort of colonoscopy, is done first to localize the bleed. With lower GI bleed, there's no particular sort of drug or cocktail of drugs that's necessarily started right away. A majority of them just sort of resolve on their own, but you still want to get a colonoscopy and go down that route to sort of localize the bleed. All right, so guys, we talked about a lot of stuff here. Upper GI bleed, lower GI bleed, different possibilities in terms of differential diagnoses, investigations, management. So why don't we summarize it? Will, what are some of the key things we're looking for when we're looking at GI bleed?
Oh yeah, for sure. So our key symptoms, again, the 3 big ones. So we have melena, again, which is the dark, sticky, tarry stools. You have hematochezia, which is again the bright red blood per rectum. And then you have hematemesis, which is the vomiting up of blood, whether that be bright red blood or blood that kind of looks like coffee grounds.
And when you're approaching a patient with a gastrointestinal bleed, you really want to think of that upper GI versus lower GI, separated by our friend, the ligament of Treitz. And so for the upper GI bleeds, you want to think, is it a potential variceal bleed in the patient with known liver disease, or is it maybe a non-variceal cause in some of the ones we reviewed earlier? After that, if that's not the case, then consider possible lower GI bleed. And in that case, you have lots of different potential causes, things we talked about like diverticular disease. Not something you'd possibly see in pediatrics, but something you definitely see in an older individual who has had a history of constipation, or maybe even something like a colorectal cancer.
Mm-hmm. And then from a management perspective, the first thing you want to check is, are they stable or not? If they're not stable, first you want to stabilize them. And you want to follow it up with some blood work, some basic investigations that we talked about. And then ultimately you want to get a scope to localize the bleed.
There we have it. So thank you very much for listening to our first episode of Making Clerkship Click on acute GI bleeding. We're going to be going through a number of different topics in subsequent episodes, looking through all different types of medical specialties. So please stay tuned, and thanks again for listening.